procedure, and the samples were sent for pathology, which confirmed endometriosis and diverticulitis as well. What's the pathophysiology of diverticulitis?
So diverticulitis occurs because there's an increase in intraluminal pressure. It typically occurs in the sigmoid colon. And what happens is the mucosa and submucosa penetrate through the vasa recta in between the tena coli.
And what's the anatomic background for that?
The anatomical background would be that there are two layers of mucosal wall, which would consequently mean that there is a weakness in the wall, and therefore you get herniation of the diverticular through, which can then become inflamed.
So you mentioned the intra-abdominal pressure. This is obviously very important to mention the unique. So the outer longitudinal layer is not a continuous layer. As you look at this image, you have three small bands as an outer longitudinal layer. It's not a continuous layer anymore. That's why these areas are actually weak, and this is where diverticular disease could happen. The other thing is, into the inner layer, you have the vascular structures and the nerves, so vein, arteries, and nerves, all right? And then they come out of the wall, so they create a pressure point or a puncture point. And this is where, can you hear me?
Yes, this is where I can hear you. Can you hear me? Hello? I can hear you.
The whole explanation for it.
Yes, I can hear you, Dr. Mansur. Can you hear me?
Yeah, I can hear you now. Go on.
So then you were just saying that there is essentially three bands of muscularis propria in the longitudinal plane, and that it's a non-continuous band, and therefore you've got a bundle of nerves, or veins, arteries, and nerves that can essentially herniate or penetrate through, and that subsequently can then become inflamed.
Correct. This in addition to the increase in the intra-abdominal pressure, all right? So intra-abdominal pressure on its own will not be enough. So the unique anatomical structures and the presence of vasa recta is actually very important as well to mention. All right, so how neutrophils migrate to the site of inflammation?
So neutrophils can migrate to the site of infection in 4 stages. The first stage would be rolling and tethering. The second stage would be that they transmigration. So they would then, second stage would be adherence to the endothelial wall. Then we get transmigration of the neutrophils to the site of inflammation. And then finally, we get transmigration to the site of chemokines, such as interleukin-6 and other cytokines that are present.
That's right. So migration, rolling, adhesion, transmigration, and finally chemotaxis. And then the process will continue by phagocytosis through the phagocytes, and at the end, destruction of these phagocytes and the resolution of the inflammation at the end. All right. But you want to mention the migration happened through 4 stages. Rolling, adherence, transmigration, and chemotaxis. You want to mention the word chemotaxis.
Yes.
All right. Good. What is the lifespan of neutrophils?
The lifespan of a neutrophil is 5 to 7 days.
It's about 7 to 14 days in the bone marrow and 12 to 24 hours in the circulation. All right, so this question, there was a lot of fuss about it because everyone who said 7 to 14 days and stopped there didn't get the mark. All right, so you want to be very specific. And the bone marrow, it's 7 to 14 days, and the circulation is 12 to 24 hours. All right. A few days following the surgery, the patient developed left inferior fossa collection. What do you think is going on?
So here I would be worried about a pelvic collection or abscess that has been retained, or I would be worried that a diverticulum has ruptured.
I want you to go back to the stem, right? Do you remember the stem? So the stem said the patient had diverticular disease and underwent Hartmann procedure.
Yes. So given the fact that the patient has a Hartmann procedure, I would be concerned with, or my differential diagnosis would be a intra-abdominal collection, such as a abscess. I'd be worried about a hematoma. I'd be worried about an anastomotic leak, and also I'd be worried about a ruptured diverticulum.
So retained collection, diverticular abscess. I think I actually need to add anastomotic leakage here. Anastomotic leakage, I think, is very important to mention here. All right, what antibiotic to start the patient on?
So I would like to consult my local microbiologist, adhere to local trust protocol. In my current practice, we currently use AMG, which is amoxicillin, gentamicin, and metronidazole. However, in certain circumstances, you can also use clindamycin as well.
What's the initial management of acute diverticulitis?
So this can be based upon, so first of all, I'd like to do a full history and examination for the patient. I'd like to manage the patient according to CRISP protocol and do a full examination. like to organise some investigations, both non-invasive and invasive. The non-invasive would be doing a full blood count using these LFT CRP. I'd like to also do an abdominal X-ray and an ABG, including lactate. And the invasive investigations I would consider would be a variant and rigid sigmoidoscopy. Measurement can then be based upon Hinchy classification, which is 4 types. 1 and 2, which is typically an abscess. We can manage them conservatively, keep the patient nearby mouth, IV fluids, bowel preparation of good toileting measures, and antibiotics. And if the patient perforates, then we can do a Hartmann's, and going back to the abscess, they can be managed either with open drainage or CT radiologically or interventional radiology guided drainage as well.
Very good. So very well done. So I asked you what's the initial management, and you went through CREST protocol. So that's very well done. So you want to do a full A2 assessment. You mentioned history, examination, investigation. You used a very good classification for investigation, which is bedside, labs, imaging, and invasive investigation. The barium enema is not one of those investigations that we offer, but
Yes.
it's okay to mention it as well, as long as you mention others. Endoscopy, you need to be really clear if you're going to do a colonoscopy. So correct. So it's going to be non-urgent, and you would have to wait until the inflammation has resolved. Otherwise, you're risking a perforation for the patient. And if the patient is very unwell and you diagnose acute diverticulitis and they're currently septic and you worry about abscess, you want to do radiological drainage with laparoscopic lavage or emergency surgery like defunctional and Hartmann's procedure. All right. So you just need to work out a way to give an answer to this question in less than a minute. All right. So in about 40 seconds, you have to finish the answer, because otherwise it will take so long. The examiner will not even listen to you and you might end up losing marks. All right. So let's talk about endometriosis. What are the theories of endometriosis?
So there are 4 theories for endometriosis. The first one is retrograde bleeding, which is where you get a transcolonic migration of the blood from the endometrium into the colon. The second theory is the malignant theory. So this is where cells metastasize from the uterine lining or endometrial lining to the bowel via lymphatic spread or hematogenous spread. The benign theory is that it transmigrates to distant sites. And finally, you have the stem cell progenitor theory, which is where the stem cells of the mesentery or the colonic epithelium essentially go differentiate lineage into direct endometrial tissue.
Good. And why is endometriosis painful?
So endometriosis is painful based on 3 things. Number 1 is that you can get adhesions, so you can get endometrial adhesions causing pain. Number 2 is that you have menstrual bleeding. And number 3 is you get the release of substance P from pelvic pain.
So you don't, in endometriosis, you don't get an endometrial adhesion, right? Because the whole essence of endometriosis is that it's presence of endometrial cells outside the uterus, right? So you get pelvic adhesions, right? Or periuteric adhesions. So that can be very painful. And the endometriosis will be synced with the menstruation, and the patient can bleed into the abdomen. And that's why it's going to be painful, because they're basically getting an intra-abdominal hematoma. All right, this bleeding will not come out. That's why it's painful. And you will notice that the classic picture of endometriosis is that it's a cyclical pain, right? So it's very well synced with the endometrial cycle or the menstruation. All right. Does endometriosis increase the risk of cancer?
Yes, it increases the risk of ovarian cancer by 3 to 5 times.
Correct. So risk of ovarian cancer rather than risk of endometrial cancer. So I think good, you will find that I skipped some questions because these questions are actually never given the exam before, but I think it's a detailed guidelines for managing diverticular disease, just to get a bit of background when you're studying, but they're not necessarily needed. For example, later management of acute diverticulitis. We don't really touch base on that. We said we're going to do colonoscopy or C2 colonography on the later date until the acute diverticulitis phase subsides, and then you can do elective resection, or you can decide on an elective operation, basically, rather than an emergency operation. But I think these questions are not necessarily asked in the exam. But I think overall, very well done. You just need to, if we go back to the pathophysiology, this is a very important question. It's usually your opening question, and you need to make the opening question, it shouldn't go wrong, all right? So you have always to make the first question, you have to smash it and just make sure that you're giving a very good answer. Otherwise, the whole scenario will not go very well, all right? So to summarize that, so you have intra-abdominal pressure, intraluminal pressure, and
Yes.
the tinea coli, which is not a continuous band, but rather a 3 layers or 3 bands, and finally the vasa recta going through the wall of the colon. All right. All right. Let's go to aortic stenosis. What are the
Yes.
causes of aortic stenosis?
So, well, broadly speaking, there are three causes for aortic stenosis. The first one being congenital, so you can have a unicuspid or bicuspid valve. The second is the most common, which is calcification. That typically occurs in elderly patients over the age of 70 and associated with risk factors such as hyperlipidemia and diabetes. And the third is from rheumatic heart disease, so post-inflammatory fibrotic changes. That typically occurs in the young.
What are the causes of sudden death in this condition?
That would be aortic dissection and myocardial infarction.
And how would you calculate coronary perfusion pressure?
So this is calculated by aortic diastolic pressure minus the left ventricular and diastolic pressure.
And how does stenosis occur?
This would occur in 4 stages. The first one would be lipid accumulation. The second one would be inflammation. The third then being calcification, and then the fourth being stenosis.
Right, and what's the pathophysiology of aortic stenosis, or the pathophysiological sequelae of aortic stenosis?
So the first thing that would happen is that you would get left ventricular hypertrophy. This is because the left ventricular resistance increases. And because of that, you get an increase in afterload because there's lack of blood leaving the left ventricle into the left atria. And therefore, the volume of blood increases in the left ventricle after systole. And then you subsequently get left ventricular hypertrophy. Because of that increase in afterload, you then over time get reduced elasticity of the left ventricle, and that reduces your coronary blood flow, and subsequently coronary perfusion pressure decreases. And then finally, you get decreasing preload, and that subsequently is because of the backflow pressures into the pulmonary vein, and therefore you move from left-hand sided heart failure into right-sided heart failure, and subsequently get cor pulmonale.
What are the complications of aortic stenosis?
So the complications of aortic stenosis would be, number one is you'd have a syncope. Well, typically it's patients would be asymptomatic, but you can get angina, you can get syncopal episodes, you can get dyspnea and shortness of breath, and other things that you would get complication-wise would be is increased risk of stroke and also venous thromboembolism.
What's the most likely cause of arm weakness following aortic valve endocarditis?
So this would be a thromboembolus that has subsequently caused a stroke and therefore unilateral arm weakness on the contralateral side to that of the stroke.
And which coagulation system is not affected by warfarin?
So this would be the intrinsic pathway because warfarin is a vitamin K antagonist and affects factors 2, 7, 9, and 10, protein S and protein C, and therefore that would be most as commonly associated with the extrinsic pathway.
What's the definition of a thrombus?
So the definition of a thrombus is a solid material that is formed by blood constituents such as platelets and fibrin.
And what is the definition of embolus?
So a embolus is a solid clot formation formed by the aggregation of platelets and direct relation to that of thromboxane A2.
What are the types of valves used in valve replacement, and what are the operations?
So the types of valves can be mechanical or tissue valve. So the other things that we typically can also do is a Ross procedure. So that involves taking a native valve that's functional and implanting it into the stenotic valve. You can also do minimally invasive procedures such as a balloon expansion procedure and also a trans-aortic valve replacement through the femoral artery.
Go on. Sorry, go on.
So the mechanical valve is typically long-lasting, it's durable, it requires lifelong anticoagulation on warfarin, and also there's typically associated with mechanical noise such as a large click. The tissue valve is something that is a human or graft from an animal. It's less durable, there's no anticoagulation involved, and patients typically have a lower risk of PTE.
What is the management of infective endocarditis in patients with metallic valve?
So here, given the fact that the patient has infection and infective endocarditis, the primary thing that would need to happen is the valve would need to be removed. This is because it would create a septic focus. and also create a subsequent biofilm, and this can lead to a non-functioning valve.
What is the cause of microscopic branching hyphae on the removed metallic valve?
So given the fact that the patient has hyphae, I'd be worried about a fungal infection. So this would consist of either Candida, Aspergillus, or Tryptophyton. There are other fungal species as well that can cause hyphae.
You mentioned early the mechanism of action of warfarin, which is a
Yes.
vitamin K dependent. What are the complications of being on warfarin?
So the complications of being on warfarin are that there is a increased risk of bruising. So patients typically can have a minor trauma and can have increase in bruising. They will need regular blood tests to monitor their INR. Sometimes warfarin can be reversed acutely in traumatic situations, but INR would require monitoring. And it also can increase your risk of bleeding and VTE.
And how would you monitor warfarin?
So warfarin needs to be monitored on INR. If the patient has a metallic heart valve in this scenario, for example, INR would need to be between 2.5 and 3. It's typically done by INR nurses that take a regular blood test. Also, you need to look at coagulation, so APTT, prothrombin, and also other coagulation screening tools.
Very well. So you will notice that I haven't given you any feedback during this practice. I was timing you, and you finished basically 10 seconds early. So this is how tight the exam could be. All right. So I was timing you from the beginning. You started at basically when it was 20 minutes in the meeting, and now it's 28, 50 minutes. So obviously you do have about 9 minutes to get to the end of the scenario. I think well done. So that you finished it. This is considered as a long scenario, but try to think about it if it's melanoma that we did today. Very long scenario. So that's why it would be good to re-practice it at some point during the 13 mocks that you have. Let's go and feedback now. I think overall it went very well. I think the cause of aortic stenosis, you can make it shorter. So I would just say, as we agreed before, to the point, short and succinct. So you just say congenital, senile, and post-inflammatory. Congenital usually unique hospital by, and I personally like mentioning the headlines before going into the details. All right.
Yes.
So because literally the examiner might stop listening to you, which is works for your interest.
In your favor.
So you say congenital, senile, post-inflammatory. Congenital could be unique hospital bypass. And senile is more than 70 years, and patient with risk factors such as diabetes and hyperlipidemia, and post-inflammatory between 30 and 70. And this is basically usually mitral valve, and that happens with patient with rheumatic heart disease. That's it. All right. So you can definitely make this shorter. Cause of sudden death, you mentioned it very well. You've mentioned this very well. Again, you've mentioned this very well. You can just go to the point as well. But I think you mentioned it very well. Again, this is, you talk longer. And I think you, again, use the headings. You just go for the headings first. So the pathophysiology can be divided into 3 points: left ventricular hypertrophy, increased myocardial load, and decreased preload. All right. And then you can go into the details of that, and you can explain whatever you want. And just make sure if you're taking longer than 40 seconds in any exam answer, that includes your communication, procedure, whatever the part of the exam is, you're wrong. All right. So I wouldn't take more than 40 seconds in any question at any point. It doesn't matter how long the question is.
Yes.
Right? And probably the longest part will be the trauma cases in the acute.
I've seen that on your recordings for the S previously on the drive. People have taken to get through their A2E or mobilization of C-spinal. You just really take 3 or 4 minutes and they don't get through the end of the stem. So it really does have to be quite slick.
Correct. So go for the titles. Literally, the examiner might stop listening to you or might look for the keywords that you want to say. Complications, you could have said more than this, all right? I would start by, so the complication of aortic stenosis. So this is an outflow obstruction. So that means hypertension. That means left ventricular hypertrophy, because the outflow of the left ventricular hypertrophy, and this is congestive heart failure, can lead to ventricular tachycardia, can lead to mitral regurg, can lead to atrial fibrillation, and this can lead to cor pulmonale. If you think about it in that sequence, that'll be much easier to remember.
Well, because I mentioned it in the pathophysiology that it would naturally lead on, or they'd just tick. But clearly, you have to answer each question in sequel, right?
Examiner has a checklist that he has to fulfill. All right. So I'll ask you all the questions. Even if you try to speed up and answer the next question, it would actually work against you. All right. So try not to do that. You've given a good answer to this, no problem. A good answer to this. I think the whole warfarin part, you've answered it very well. Definition of a thrombus. I know everybody goes for this one. That's why I've written it, but I don't like it. I like the second one more. This is from Robbins. So it's a
Okay, yeah.
pathological formation of an intravascular blood clot during life.
Okay.
So this is the definition from Robbins pathology, right?
Yes.
So an intravascular blood clot during life. It's an again, I like the second definition more than the first one. It's much more accurate. It's an intravascular mass that travels and occludes the downstream vessels, resulting in occlusion of that vessel. All right. They give the same meaning. You're just trying to be using a little bit more complex word, which they like, basically.
Yes.
I think the comparison, you could have made it slicker as well. So it's a tissue valve is noiseless, doesn't need warfarin. And again, I would say, I think I mentioned some of this feedback to one of your colleagues today. She was comparing between benign and malignant. And she kept saying benign would be this, malignant would be this, benign would be this. That was very boring. So here, tissue is noiseless, doesn't need warfarin, it's difficult to insert, less TE risk and lower bleeding risk. On the other side, it's the complete opposite. And you can stop here, right?
Yes.
I think you've answered this very well. Here, you could have mentioned all the examples, but to be honest, it's not really.
It's difficult. It's like when you ask for the gram-negative diplococci, and
Which I need to mention the gram-negative.
Yeah. Well, it's your famous city, I think, isn't it, from your YouTube videos from your home? But it would be Haemophilus, Brucella, Actinobacter, Moxarilla catarrhalis. I can't remember. There's always one that I can't remember.
So it's I think you forget the most famous one, which is Neisseria meningitis, right?
Yes, that's the one.
So Neisseria, it should come. So it's a BNHA.
That's the one, BNHA. Yeah.
Good. I think overall it's a good performance. It's just a key point is the pathophysiology and just try to make it a little bit more slick. But otherwise, it went very well. All right, let's go to gastric carcinoma and see how you do with that. So a male patient has been diagnosed with gastric carcinoma, have undergone gastrectomy and splenectomy. The pathology report, which is available for you to see, indicates the presence of signature carcinoma and cancerous cells on the margin. What are the risk factors for gastric cancer?
So the common risk factors for gastric cancer would be Helicobacter pylori, chronic atrophic gastritis, and other risk factors would be blood group A, FAP, and diet high in nitrosamine. There are other things as well, such as
what's the most important one?
Helicobacter pylori, so chronic atrophic gastritis.
Great. So H. pylori is the most important one to mention. Smoking and tobacco can be mentioned as well. I can give this classification if you would like: environmental factors, host factors or patient factors, and genetic factors as well. How would you classify gastric cancer?
So this can be based on two classifications. The Lauren classification can be based into intestinal, interstitial, and diffuse. The intestinal is typically environmental, and diffuse is based on a singlet ring and thickening of the stomach wall, such as linoplastica. The Borman's classification is a macroscopic classification based on gastric cancer. It's graded 1 to 4, and 4 being the infiltrative type, such as linoplastica.
Right, very well done. I think that's a very good answer. But there were people made a fuss about this question, and the examiner was not really satisfied every time. So that's why I tried to cover all the possibilities, which I think you did in your answer as well. So you can classify it into many different levels based on depth of invasion, which is early or advanced, the macroscopic growth, which is flat, exophytic, or threaded diffuse, the microscopic picture, which is intestinal and diffuse, and you can go into detail of the intestinal and diffuse type because those are the most important. All right. Diffuse type is the more aggressive one. It has signet ring and it leads to desmoplasia and is not related to H. pylori or intestinal metaplasia. All right. So like we did, try to cover both basically.
Right. Okay.
What's the most common type of gastric carcinoma?
So this would be adenocarcinoma. And the type of adenocarcinoma would be tubular adenocarcinoma.
Good. What's the role of CDH1 in development of gastric cancer?
So CDH1 is associated with familial hereditary gastric cancer. It is a tumor suppressor gene that corresponds or codes for E-cadherin, which would then cause subsequently a loss of function if there's a mutation in CDH1. That's
right. So it's loss of function, a mutation in tumor CDH1. Good. The pathology report, can you discuss it with family? We mentioned it earlier.
Yes. So this is a cancer of the stomach. It has incomplete resection. It's likely to require further surgery, and recurrence is a possibility.
Very well done. Yeah. That's great. So this is, we talked about this morning. This is great. Yeah. Exactly. So you just say very direct and to the point. And obviously, if you're speaking with the family, you will explain it better, obviously. But with an examiner, you can just mention the key points. The patient developed post-operative confusion. Could you explain why?
Sorry, can I move on to the next question, please?
Say again?
Sorry, I don't know. Can I move on to the next question, please, and come back to it at the end of the stem?
7-10 days later, the patient had axillary vein thrombosis. What are the risk factors for that?
So the risk factors for axillary vein thrombosis would be based on that Verco's triad. So here they would be metastases, which it would cause hypercoagulability. There could be endothelial injury secondary to previous investigations that the patient could have had or previous surgery.
Right. 6 months later, the patient came with ascites, deranged liver function, and hepatic metastasis. What are the 2 pathological tests you do?
So here I would like to do a acidic tap and cytology, and I would also like to do a liver biopsy and MRI. So consider doing a tumor marker. I'd also like to consider
So
doing a tumor
MRI is not
analysis.
necessarily a pathological test, so you want to be specific about pathological tests. What's the mechanism of action of low molecular weight heparin?
So low molecular weight heparin, such as tinzaparin, affects the direct pathway. So it would affect essentially factor 10A and then the conversion of fibrinogen.
That's fine. We'll come to this. What are the treatment options for gastric cancer?
So the treatment options for gastric cancer would be dependent on the extent where there is evidence of metastasis. The options would consider doing chemotherapy and also doing, if the patient had ascites, consider doing continuous acidic tap and cytology. They could also have cytoreductive surgery as well.
All right, so that's fine. I think what I mentioned is okay in the treatment. This is it for the scenario, which I think was done in good time. You finished early. Let's go to the last question, which the patient had confusion. What do you think is going on post-operative?
So I didn't want to say anything here that could impinge the stem, but I was thinking the patient could have had a query PE or a query stroke. That's what I was considering, given the fact that they had metastasis as well. Yeah.
That's very good.
But I didn't want to say something and it be wrong.
No.
So
Yeah, that's very good. So I think the answer here is, so the patient is alcoholic, all right, which I'm not sure if it was mentioned in this stem. So alcohol withdrawal is one of the symptoms. We would like to explore more and do confusion screen. So like I said, I'm just giving you a clue here on how you would answer this question. But the way that you said it, stroke and PE, very reasonable. So you just want to say, well, so this is a post-operative confusion, and I would like to assess the patient and establish a differential diagnosis, which in my opinion will be starting by pulmonary embolism, stroke, and sepsis, and also alcohol withdrawal. The patient is alcoholic. I think it will be mentioned somewhere in the stem that the patient is alcoholic, which I think I haven't mentioned here, which I should.
But on the day it will say that, won't it, on the stem?
Correct. When you're faced with one of these questions, just go to the basic principles and do what you would normally do in your practice, right? So sepsis should be on the top of your list. Whether intracranial mets is very unlikely, but you could mention that as well. The patient is on low molecular weight heparin. You can think about intracranial bleed, etc. So just establish a very wide differential diagnosis, and you say it will be based on my assessment. But given the patient is alcoholic, I would consider alcohol withdrawal at the top of my differential. All right.
Yes.
I think overall that's a good practice. I didn't time you this time, but I think looking at the clock now, it makes sense that you finish early as well, which is really good. Let's do this one, which I think people again make a fuss around it, but I think it's an okay scenario. What is a gastrointestinal stromal disease?
So GIST is a gastrointestinal stromal disease. It is typically a mesenchymal tumor that evolves in the stomach and small intestine. It's associated or arises from the cells of Cardiac, and it is typically involved in tyrosine kinase mutations based around platelet-derived growth factor and CTK oncogene.
All right, so you pretty much answer the first 3 questions, and how it differs from gastric carcinoma.
So the GIST is typically 1 to 2% of stomach cancers. Resection requires a wedge resection. It has a tendency not to require a margin when resecting, and it metastasizes hematologinously, and the lymph node dissection isn't required with the tumor. The gastric cancer, on the other hand, arises 95% of the time in stomach cancer. It's of epithelial origin rather than intestinal cells of Cardiac. It requires a gastrectomy and it requires a margin of 5 to 10 centimeters. The lymph node also needs to be dissected as well to help with staging and spreads lymphatically.
All right. Very well done. Following mass excision, the mass has recurred. How to confirm if this is recurrence or not?
So the recurrence would need to be done with a biopsy and immunohistochemistry, and this can be typically done under endoscopy. You could also do a CT scan as well with contrast if you wanted to.
Correct. So again, you can sort of, it depends really. So you can give a full answer here by thinking assessment and history, exam, etc. And you can also give a direct answer. I think here it's okay to give a direct answer that you're going to take a biopsy and do immunohistochemistry. What is CD17?
So CD17 is a tumor marker and it is a transmembrane tyrosine kinase. It can encode for KIT gene, which is 95% present in GIST and also is typically responsive to imatinib.
Good. And what's the mechanism of action of tyrosine kinase inhibitor?
So it inhibits the KIT gene and also platelet-derived growth factor alpha.
Very good. And what are the most associated risk factor with gastric adenocarcinoma?
The most associated risk factor for gastric adenocarcinoma would be, sorry, pass. I don't know. Can I move on to the next question, please?
I think you mentioned that just in the last scenario, right?
Was it H. pylori?
Correct.
Because now we're moving on to the IC.
What is H. pylori?
Oh gosh, H. pylori is a flagellated gram-negative bacteria that secretes urease.
And how would you treat it?
So it's typically treated by triple therapy, which involves antibiotics and a proton pump inhibitor. I would treat it based on trust protocol and antibiotic regime, dependent on my local trust.
Can you give me examples of antibiotic?
So I would treat it with metronidazole and amoxicillin.
Correct. Is there anything else?
Not off the top of my head, I'm sorry.
So it's MAC, right? So MAC, the erythromycin as well, okay? But you don't give the triple therapy. You can give two at a time. So you can give either MA or MC, okay? Other cancer than adenocarcinoma H. pylori can cause?
So H. pylori can additionally cause squamous cell carcinoma.
Okay, the patient has macrocytic anemia. Why do you think that?
This is because the patient has a reduced factor, which is predominantly on parietal cells and will reduce in vitamin B12 or absorption.
Yeah, like consumption, it's absorption. I think you can mention a little bit more in this question, and also cancer is mainly the lymphoma, right? Due to chronic irritation, so it's multoma or multiple lymphoma. All right, so let's go back in terms of feedback. I think those questions you've answered them very well. Yeah, I didn't miss a question. We talked about it.
Risk factors. Oh yeah, very sorry.
Yeah, question you give a very good answer. This one, immunohistochemistry is the key. They can always ask you, what is immunohistochemistry, which I did ask you this morning. So every time I think immunohistochemistry will come up, they will ask you, and what is immunohistochemistry? All right. So literally every time it will come up, they will just ask you, and what is it? And you have to define it, and what is the antigen antibody reaction? You have to say complement fixation.
Complement. Yeah.
CD117, you've answered it very well. Again, mechanism of action, okay. Pylori, you could have said a little bit more. It's a helical, flagellated, gram-negative that resides in the stomach, and you can also talk about the environment that it prefers. Yeah,
be acidic. Yeah,
so live in a highly acidic environment. It doesn't like acidic environment, but it creates a layer around it of urease, of ammonia, which protects it, so it can survive in a highly acidic environment. Okay, it resides in the stomach due to urease, which converts urea into ammonia, and that will sort of lay around it. And then the shape is very important to appreciate how the shape can create the pathology of a peptic ulcer, and then consequently disease. The helical shape, so it's easy to penetrate. The flagella, it gives it move and mobility, and the ammonia, that it can fight acidity. All right.
Yes.
I think you said it well, but PPI and the MAC, which is a 7-day course, usually give 2 antibiotics at a time. Sometimes, if it's chronic and for 6 weeks, you would give the triple antibiotic. Question is just a learning point that you would need to remember. Macrocytic anemia, you want to talk about intrinsic factor, which is secreted from the parietal cells in the fundus, and decrease of that due to chronic gastritis, lead to vitamin B12 absorption. You also mentioned the hepatotoxicity. No, sorry. I think, hepatitis from tyrosine kinase. This is not relevant. It can also lead to B12 deficiency. Okay. I think very well done on this scenario. What else do you want to do? We have a
quick one. Should we do the squamous cell carcinoma? Have we got
yeah,
time for one more?
yeah, we have time. I think there is another candidate coming at 9, but we
Yes.
do have 10 minutes. We can do the squamous cell carcinoma. What is a squamous cell carcinoma of the skin?
So it is a skin of cancer of origin. It is the second most common cancer and can affect mucosal, such as the oropharynx, cervix, and skin.
So yeah, this time I have to specify to you. So
Oh yeah,
squamous cell
you
carcinoma of
specified,
the
yeah,
skin.
skin. Yeah.
So you'll have to
Sorry,
say
yeah.
this is a malignant cancer.
Yeah.
So it's malignant, not benign, that arise from squamous epithelium in the skin. All right. This is
Those
the
areas
second
of them.
most common,
Yeah.
so it's around having the sun exposed. You can mention this as well, but the
Yeah.
actual definition that it's a malignant type of tumor that comes from the squamous epithelium. What's the granulation tissue definition?
So granulation is new connective tissue that is formed by secondary intention. It involves fibroblasts, angiogenesis, and chronic inflammatory cells. It from the base upwards and fills the lesion, and it is formed, or the end stage is when a fibrous has been produced.
Okay, I think you sort of answer the next question, which is the role of granulation tissue. So it fills the wound from the base up to heal by secondary intention. What are the factors affecting wound healing?
So there are 4 factors that can, broadly speaking, that can affect wound healing. The first is patient factors such as obesity, diabetes, steroid, radiotherapy, and hypertension. The surgical factors, which would include the environment, so aseptic technique and laminar flow. The wound factors would be those preceding foreign body, infection, the blood supply, and a hematoma. And lastly, the surgical factors, which would be the suture type, such as or nylon, approximation of the wound, and also the wound tension.
Good. The key difference between hypertrophic and keloid scar.
So hypertrophic scar is one that is confined to the wound margins. It is also that does not subside. There is a family history associated with it, and it's typically in the skin creases. Whereas keloid scar is extends beyond the wound margin. It's in Black and Hispanic people. It's associated with blood group A. It does not subside, and there is no history associated with it.
Yeah, so I think the key points to mention is the errors beta, right? So hypertrophic is confined to the wound edges, and keloid is beyond the edges. And yes, I
Yes.
agree, it's in Black and Hispanics, and the other one happens in the skin creases on the flexor surface. All right, I think, yeah, one with this one's usually squamous cell carcinoma would come with basal cell carcinoma, and they will continue talking about squamous cell carcinoma because it's a very short scenario, but you can think about it, basal cell carcinoma and the squamous cell carcinoma, that would be a very long scenario, all right? So
Yeah.
squamous cell will not come in its own. So usually will come with basal cell carcinoma.
Yes.
Okay. So I think that's perfect for today. So we've covered 6 scenarios and
Yes.
5 scenarios. And we've done today as well the melanoma.
Yeah.
Previously, I think we've done men 1 or men 2. I don't
Meant
remember.
to. Yeah.
I think you're doing really well. You really just need to keep doing what you're doing now. I think it seems that your study plan is working. So just keep doing what you're doing.
Do you have any advice? Sorry, that's possible to interrupt. Do you
Go
have any advice in terms of how I should schedule my time between anatomy, pathology, and I think anatomy is my weakness. Similar is quite a familiar thing dealing with. There's obviously some nitty-gritty stuff, but broadly speaking, it's the day-to-day job. And obviously now I have 2 months left, so I was just wondering if you have any generic advice in terms of how I can get over the hurdle of this exam with 2 months left and where to
I
put my
think you
time.
need to go through anatomy and be brutal in that. You need to go through anatomy every day because anatomy is very easy to forget. So you'll have to
Okay.
do at least an hour of anatomy a day. Right?
Okay.
At least an hour. So it doesn't matter what you're doing, just a book or whatever the notes that you're using,
Yeah.
and just read anatomy very randomly. So when
Yeah.
you reach to that level, and this is in my opinion, and people might not be convinced with that, but I personally like, when it comes to studying. So if you're very chaotic after studying, reading a structure and you went through it very well and you know curriculum, you need to be very chaotic and just open the book and read anything. All right. This is the way that you can do active recall.
Okay.
I think if you have sort of a similar level or even slightly below that current level that I can see in pathology, and if you have that similar level in anatomy, I think you just need to start to be very random and just don't make a plan, just to make sure that you have an hour of anatomy every day and just read anything.
Okay.
Mhm.
Can I ask, do your YouTube cover all the recalls for anatomy as well? Because I've subscribed to your channel on there as well, so that should cover it,
It
shouldn't I? If I watch all the
it
videos
it
and make the
does
notes from there.
it does cover all the anatomy.
Yeah.
Basically, for knowledge, it 100% covers all the knowledge. For
Okay.
communication, all the communication.
Yeah.
For what else? Examination and procedure is the only deficient part because I think I can make examination and procedure
No,
online.
no.
I think this needs to be in a
Okay.
course.
Yes.
History and communication is done as well in like
Okay. Can you,
apart from examination and procedure, everything is covered.
that's okay. Okay. Don't run a course in person at all, do you?
Well, to be honest, Rami is coming to London and he was
Okay.
thinking to do a course. He will advertise if we're gonna do one. To be honest, I'm very busy, so I'll leave it to him.
Yeah.
If he does one,
Okay.
he'll definitely advertise.
Okay.
Yeah.
And thank you so much. I think I've
Course.
transferred the £325 that my father has to
Yeah.
yourselves. If I need to book more sessions, I think there's a week where you've got a lot
I,
of sessions,
I,
a
I
week
I
off.
think,
Yeah.
mate, I'll be honest with you. I think just wait for now. You booked enough
Okay.
sessions. Let's
Yeah.
see how you go, and if you need sessions later on, we can talk about it. But I think
Okay.
13 sessions is actually enough number, and you're doing well. I haven't seen you in anatomy, but from what we've practiced so far, you're doing very well.
Okay.
Okay,
Thank you so much for your time. And
perfect.
yeah, if you have any other advice, let me know. And I'll send you the stations for CS over to you for our
So
next session.
it will be helpful if you can. I mean, you have to do that, but it would be helpful if you can write, that include these sessions. So basically,
Okay.
I tend to forget things quite easily. So
That's okay. Yeah.
let me show you what I mean by that. So I created, name. This is your mock one. So I
Okay.
can do the same in
Yes.
all the mocks. So it'll be
Okay.
easy to go through them. So mock 2, mock 3,
Ah,
etc. So if you
I
send me
see.
that, so all the scenarios will come straight away and I don't have to think about it. So if you make a
Yes.
plan now, get the whole curriculum and just make a plan now for all the scenarios. And try to give me some flexibility because I think the maximum we can do in an hour is 6 stations. That's the maximum.
6. Okay.
All right.
Okay.
But be some flexibility. So try to give me 8 stations every time.
Okay. That's and then
So
post
so
the exam. I'll just ask you to randomize them. I think, or the ones
yeah,
from the list that I give. Yeah.
yeah,
The last thing is, could you kindly send me the recording if you get a chance? That'd be
yeah.
great as
That's fine.
well. Yeah.
I'll
Because
do
I'll
that.
do it on the car on the way into work. Yeah.
Yeah, we'll do that.
Thank you so much, and
Sounds good.
take care. And I look forward to seeing you on the next mock on the group and on the 6th of April.
Perfect. See you later.
Thank you. Thank you. Take care
Bye.
now.
Bye.
Bye bye bye.
Hi, how are you?
Yes, I'm fine.